Good evening and welcome to Doctors on Call. What would you like to know about male health concerns like incontinence, prostate and kidney issues, and bladder disease? I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School here in Duluth. And I'm your host for tonight's program on men's health and kidney stones. We'll be happy to answer your questions. Just give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. I am pleased to welcome our panelists this evening, Dr. Nathan Hoffmann, a urologist with Essentia Health Duluth Clinic, Dr. David Hutchinson, a family medicine physician with St. Luke's Lester River Medical Clinic, and Dr. Andrew Nisbet, a urologist with St. Luke's Urology Associates in Duluth. Our medical students answering the phones tonight are Maddie Grossland from Cannon Falls, Minnesota, Chris Hughes from Aiken, Minnesota, and Tyler Kuntz from Belle Plaine, Minnesota. And now on to tonight's program on men's health and kidney stones. Dr. Hutchinson, you're a family doc, and we kind of sit on that front line where we see all types of patients. With men, what are some of the common complaints that you see, or what's the most common complaint possibly?
So we field a range of questions about complaints commonly. We hear a lot of questions about testosterone levels. We field a lot of concerns about erectile function. Probably one of the most common issues that I face in the family medicine office is talking about complaints about slowed urinary stream and potential prostatic enlargement, and then questions about whether or not to screen for prostate cancer.
Very good. Dr. Nisbet, what's the prostate?
Yeah, good.
The prostate is a relatively anatomically confined organ that has a very minor role in reproduction. It is a solid organ that sits at the base of the bladder, and through the prostate, which you could, if you could imagine, is a tube that then connects to the penis, and that's where the urine actually passes through. The ejaculatory ducts also pass through the prostate.
Dr. Hoffmann, just to finish out our anatomy from a urologic standpoint, do you want to fill us in a little bit about kidneys, ureters, bladder,
Sure.
and so on?
The kidneys are basically the filtration system for our bodies. A lot of our blood flow goes through it, and we take out a lot of the toxins that our body accumulates, and it creates it and concentrates it into what we call urine. Urine flows down what's called the ureters, which is the tube that connects the kidney to the bladder. And then from there, the bladder stores it until a socially acceptable time when you want to go to the bathroom, and then and the bladder then usually contracts, and in the case of men, flows through the prostate, out through the penis, and then into the toilet.
Hutch, I'm sure in your office you see kidney stones. Do you want to talk to us a little bit about kidney stones and how they present?
Sure. Kidney stones are a very common problem. They result from the crystallization of salts in the urine. When we see complaints or questions about whether people might have a kidney stone, and when people do have a kidney stone, they typically will have sudden onset, rather severe, either abdominal or flank pain associated with blood in the urine. So pain and blood in the urine are the most common symptoms with kidney stones that are passing. Stones that haven't passed, that still reside in the kidney, don't have any symptoms.
Dr. Hoffmann, what causes them?
There's a lot of stuff that our body, like I said, is trying to get rid of, and those, if in high enough concentrations, will generally form stones. And so if you have a imbalance between how much stone-making stuff you put out in the urine, you'll form stones. Or sometimes, because our body knows we have to get rid of this stuff, it puts in stone-blocking stuff. And it's another problem that can happen is that there's not enough of that stone-blocking metabolites in your urine that would actually allow stones to form. So it's a balance between the stone-making stuff and the stone-blocking stuff. If there's not enough stone-blocking stuff or too much stone-making stuff, that's how the stones form.
But if we remember basic chemistry from earlier phases of school, stones form as salts crystallize, and no crystals can form if the solution is dilute enough.
Right.
And there are all kinds of, a number of mechanisms for stone formation, and stones can be made of different, they can have different compositions. There are different kinds of kidney stones, and they have different reasons for forming, but if we can keep the urine dilute enough, that's the best chance of preventing them from forming in the first place.
Number one reason why we work people up for kidney stone formation is we don't drink enough. You know.
Exactly.
Dr. Nisbet, then does milk cause problems?
So it's almost a contradictory topic. People think, well, the most common type of kidney stone is one that's composed, at least in part, of calcium, and so people will frequently ask me, well, then should I just stop drinking milk, or should I stop eating cheese? And that's actually the opposite of what should happen. Yeah. Most people who form calcium-based stones should be on a normal calcium diet.
Exactly.
In conjunction with a low sodium diet and good hydration, as Dr. Hoffmann pointed out.
So calcium oxalate stones, do you then ask patients to reduce their oxalate intake instead of their calcium intake?
So as urologists, what we're supposed to do when we have a patient who's a high-risk stone former is to obtain urine collections, 24-hour urine collections that will identify metabolic risks for them, including oxalate levels. And so I will reserve recommending a low oxalate diet to patients who have high urine oxalate levels.
Yeah, and it's incredibly difficult to actually lower someone's urine oxalate too, because it's a important cellular machinery for actually how we produce energy. And so even when we put people on low oxalate diets, our bodies will actually more than compensate for the low oxalate. You generally have to mute it out in other ways, put other stuff that block the oxalate from forming stones rather than actually getting them to lower their oxalate.
As a family doc, I love those answers. There are websites that will recommend to patients that they reduce their oxalate intake, which usually means reducing the vegetable intake, and those are such vitally important foods for good health overall, that it's a much better strategy to dilute the oxalate and the calcium in the urine to prevent stone growth.
The two main dietary modifications you can make are avoiding high amounts of protein. High protein diets are massive stone formers, and then, as you pointed out, high salt intake. Those two produce more calcium and more uric acid in your urine. Those will be their stone formation problems usually.
So now I'm going to drink a lot of fluids, but I also have incontinence. Why do I get incontinence?
Well, a variety of reasons. I'll hit,
jump in.
Exactly. I'll hit the easy one. The prostate is a big problem. It as we've talked about, it has a very small function in actual helping you in life, and it spends the rest of the time kind of making you unhappy. The prostate, as it grows, tends to make the bladder work harder. The bladder pressures rise in response to that. So it knows that your body knows it has to work harder to get the urine out, so it make the bladder pressures go up. And now, anytime anything that would have irritated the bladder is going to hit it, compared to before when it wasn't working so hard, it actually gets a much stronger kick, and it allows the bladder to overwhelm the brain and say, I got to go and get out of my way, and I'm not going to listen to the brain and say it's not a socially acceptable time. And so one of the main causes of incontinence in men is that what we call irritative symptoms, where the patients have an urge to go that they can't control, and then they're running to the bathroom, and by the time they get there, they're already peeing.
Other comments?
I'd say for most men, I think it's reasonable to assume that their baseline urinary difficulties come from an enlarged prostate as they age, and so that those symptoms that Dr. Hoffmann is describing are usually well treated with some simple medications that can be prescribed not just by urologists but by family practice doctors.
So when should a man have a prostate exam?
Well, if you're referring to prostate cancer screening, which is what most men are wondering about when they're asking if they should have their prostate checked, the American Urological Association has a good evidence-based guideline that I refer to for early detection of prostate cancer. And in that guideline, men at normal or average risk for prostate cancer should start getting PSA screening and a digital rectal exam when they're 55.
Hutch?
So, yeah, that's a hard question. So when to have a prostate exam? When somebody has symptoms that we want to look for clues for the cause of, such as urinary outflow obstruction or frequent urination, fever with rectal pain, things like that. With regard to screening for prostate cancer, there are a number of association guidelines about how to do that. most primary care organizations in the world recommend against screening for prostate cancer in terms of looking at evidence for benefits versus risks. They also recommend individualizing those decisions between physicians and patients, the team of physicians and patients, to help decide what's best for individual patients.
Right. The controversies, will probably go, take years to actually sort out as to when you should screen and how you should screen and all that sort of stuff. I think PSA has gotten a bad rap lately in terms of its ability to screen for prostate cancer. It is a flawed test. We've all known that for a long time, but it's still a test that has in other ways helped us. And so we tend to, and especially in America, tend to throw the baby out with the bathwater in some ways. We say, oh, it has some problems, so let's not use it at all. And I think both ways work, either to not screen in certain kinds of patients who don't want to know and who also have a health situation that doesn't make sense and a family history situation where it doesn't make sense. And there's other people who absolutely should be screened. Lots of family history or family histories of longevity where you're going to want to know whether or not they have prostate cancer. Those types of people are the ones that should be screened. And so it is definitely much more important than it ever has been to have a good talk before you just go randomly grab a test.
Yeah.
Are there dietary or physical activities or other things that can help with the prostate? No, questions about is niacin helpful? So we'll start from there.
I'm not sure I can answer that
As
question.
far as I know, niacin has never really shown anything. Everything that's heart healthy is prostate healthy, and so we've always told people to exercise and lose weight and things like that, and that helps with how their bladder treats them and how their prostate treats them and all that. Obesity is one of the main secondary risk factors for prostate cancer. So, just being healthy in that regard gives you a lesser chance of having prostate cancer, as an example.
Yeah. There's a lot of non-evidence-based and maybe loosely evidence-based recommendations for various supplements for prostate health. And a lot of men I find are on supplements that are advertised on television as being good for prostate health, and they contain varying combinations of vitamins and minerals and so on. And I think it's important for men to know that those supplements that are advertised are not labeled by the Food and Drug Administration, and so there really is no evidence to support using those.
Yeah, I agree with that too. There is some low-level evidence about possible benefit from selenium, but really we get the greatest benefit from exercise, good hydration, weight control, good vascular health.
Yep. So you two guys on the end are both triathletes.
Yep.
How hard's a bicycle on you?
Oh, that's a very good question. There have been people who have actually, the main concern is actually erectile problems, is because one of the arteries that runs right next to the pubic bone that you actually sit on is what actually has been implicated in erectile problems. And so they've actually tried to do some longer-term studies on whether or not hardcore bikers are having more erection problems, and the data that has come out of those has never really shown a clear correlation, because those guys also tend to be healthier who tend to have less erection problems. So in terms of telling guys to not do bicycling because it could potentially implicate erection issues or things like that, I think is too aggressive, because you don't want to tell a guy to not exercise basically on the basis of what could potentially happen to his erections.
Yeah. I think just anatomically speaking, for men who are cyclists or like riding a bicycle just for the sake of being healthy overall, I just tell them that they should make sure that their bike fits properly.
Right.
And if they have numbness that is concerning in their genitalia or in their groin or their perineum, then they should probably have it reassessed.
Yeah, seats can be modified to help with that issue.
There's actually even an independent suspension bike seat that'll actually split exactly down the middle so that it will have no pressure on that nerve. It's expensive, but it is out there.
What is erectile dysfunction? Hutch, we'll go to you on this one.
The functional definition of that is erections to a degree that fails to satisfy the man having the erection. So erectile dysfunction has a subjective definition, and it's individual.
The screening guidelines almost always are relational between the person and the partner. So when you give a questionnaire to assess how a man is doing with his erections, it almost always discusses, how do you feel like, does the erection achieve penetration? Does the erection satisfy you? Does the erection satisfy your partner? Those kinds of situations. And almost all the erection improving medicines, when they go for scoring improvements and things like that, show both increase in satisfaction with the partner and the person themselves as the most important guideline, as opposed to actual erection rigidity and things like that.
Anything to add?
I think it's important for men to know that they could think of their erectile function as a barometer for their overall vascular health. And frequently, erectile dysfunction is the first sign of other vascular disease.
It's not always true, but there's a high concordance rate between perceptions of reduced erectile strength and vascular disease, very much so.
One of the main causes is arterial problems of the penis, and that artery that happens to run the erections is about the same size as the coronary artery that would potentially relate to heart health.
So I suppose the same things that can cause trouble with the heart, smoking and so on, is a bad thing here too.
Exactly.
Smoking and
So
diabetes and high blood pressure.
Might be one good reason to quit smoking if you're having
Right,
trouble.
exactly. And it's also a good thing when you go to your doctor and ask about erection problems to make sure that you have said, all right, is my heart getting screened? Because that was one of the best evidences that came out of that correlation.
That's why the visit is always a longer answer than the answer to the question, can I please have a prescription?
Exactly.
What, Dr. Nisbet, what causes blood and semen?
Well, I guess we don't always really know. And when men see blood in their ejaculate, it's obviously very concerning and alarming. And we see a lot of patients for, the clinical name is hematospermia. And technically, if the man is in overall good health and his physical exam is normal, there's really no other workup indicated.
It was bandied about for years that meant prostate cancer. And because of that, a lot of people come asking, does this mean I have prostate cancer because this came from my prostate, and is that a sign of cancer? And the actual answer unequivocally is no. The reason why it was thought that way is because we told these guys, you might have prostate cancer if you see blood in there, and they kept coming back, and they were more likely to get diagnosed just because they saw their doctor more often. Long term, it doesn't mean anything.
So it can mean infection in prostate or seminal vesicles. It can mean tumor in the testicle. Most often, it doesn't mean anything bad.
Blood in the urine, painless.
Blood in the urine is a whole other question. That's a concerning finding. If you see it, 90% of the time we're going to find something urologic causing it. They're not all cancerous, but we're going to find something of potential concern. Kidney stones, kidney cancer, bladder cancer, rarely prostate cancer. It's usually got to be pretty late before it causes blood in the urine. But those other findings are concerning enough that if you see blood in the urine, you should be talking to a doctor about it.
There are so many causes of that. Diseases of the kidney, diseases of the bladder, diseases of the prostate. What we tend to think of usually depends on the patient's age. In young people, exercise can cause blood in the urine. Intercourse can result in some blood in the urine. Simple enlargement, benign enlargement of the prostate can cause, if it's bad enough, can cause blood in the urine. But there are a number of cancers that can present with blood in the urine too.
Or as Ben Owens used to say, go see your family doc.
Exactly.
Who will ask for help from his friendly urologist.
Exactly.
Yeah.
Dr. Nisbet, how long should you be passing blood after stents are removed? I guess we're in the kidney stone business now.
So this touches on the idea of surgical management of kidney stones. Frequently as urologists, we have to manipulate the upper urinary tract, the ureter and kidney in order to extract kidney stones. And one of our important tools in this is the use of ureteral stents, and these are not perfect. Ureteral stents cause a lot of symptoms, both when they're in and after they've been taken out, and patients can have blood in their urine after the stents are removed for weeks to months sometimes.
With the questions come in about someone having to get up maybe 2, 3, 4 times a night. So is there a point here where getting up frequently, decreasing stream and so on is worrisome, or how do we talk to our gentlemen out there?
In general, if it's not bothering, in general, if it's not bothering you, it's not bothering enough to get to see us. But usually when people are getting up 2 to 3 times per night, they're starting to lose sleep. They're starting to feel daytime sleepiness. And so they're generally pretty annoyed before it would ever be a risk to their health. But having said that, there's a lot of stuff we can do to help people. Getting up to go to the bathroom at night is one of the harder things to modify, simply because it's a cruel trick of nature that we actually make more urine at night the older we get. But there are still many things to make sure that you only get up when your bladder's totally full. The problem is when you get up 3-4 times a night and you're only peeing out like an ounce of urine, and then you got to go back again and again and again multiple times to get yourself empty. That's when people start to really complain and say, this is not good. Can we fix this? And it's the right time to do it.
So it depends on how much those things bother the patient. 3 to 4 times a night is a common frequency where people say, this is enough, it's time to do something about it. Those are individual decisions. I do want to make a point about sleep quality. Sleep quality is really, really important for overall health for many reasons, for heart health, for mental health, for metabolic health, for eating habits, for diabetes prevention. Sleep quality is really important. Some people fall back asleep very readily, and so those people getting up 3 times a night, it may not be very bothersome. Some people have really a lot of difficulty falling back asleep after they get up to void. That's really a problem. So,
Short primer on kidney stones, ureteral stones. Is it necessary to have them blasted?
I've seen patients. I have one patient who will never let me take his kidney stones out. He wants to pass them, and he will take literally a year to pass a kidney stone. There are other people who do a very small stone that's only been there for a day will want it taken out. If you have 2 kidneys and you're not having fevers, whenever you want us to fix it is when we want to fix them for you. Otherwise, you can pass. I mean, the data says you're not going to hurt your kidney unless you're literally passing this thing for years. So as long as you've got 2 kidneys and you're not having fevers, if you're having fevers or you only have 1 kidney, then passing a kidney stone is a medical emergency. But usually people don't sit at home with a high fever within a kidney stone type of pain.
So Hutch, as you talk about health, and we're talking about more holistic things, one of my professors in medical school said, remember boys, go home and do your homework. So is sexual activity and sexual health important for the aging male?
For some aging males, it is. Yep. Sexual health is important for mental health and emotional health, and it's important for relational health. Maybe I'll answer from that perspective and leave some of the answer for these guys as well. For some couples, it's not as important. I think that's a decision, or I think that's a discussion to have with both partners of a relationship if possible. Most people who come to ask me about it think that it's important.
Gentlemen? Is he?
I completely agree. I think that you have to look at the entire patient and his relationship to his partner and how it affects his life, and there's a different answer for every person.
Right. One of the more common times we see erection problems is after prostate surgery, and whether or not that man gets erection function back after surgery is largely a question of his relationship to his partner and what they view as sexual activity, because a lot of times the actual quality of the erection doesn't matter. It's actually just the closeness of the relationship with the wife, and they find other ways to be sexual, and it works just fine for them. And other men, intercourse is very important, and then they will be very motivated to get their erections back, and anywhere in between.
Nice. Is erectile dysfunction normal for a 65-year-old man?
Well, I think if you call it dysfunction, you can't call it normal. And I would say it's very common for a 65-year-old man, at least to some degree. That's maybe that's the best short answer.
Yeah, just because something's common doesn't mean it's normal. That's the best way.
It may be useful to point out that there, besides pills, which can be highly effective for erectile dysfunction, which also have some side effects, some rare ones of which can be serious. In obese men, weight loss, there's some grade B evidence that says weight loss in obese men can help erectile function. And in men who measurably have low testosterone levels, treatment of that condition may help erectile dysfunction.
So Hutch, I've always loved your holistic way of looking at things.
And yours too, Ray.
So what are the most, you've got 30 seconds.
Okay.
What are the most important health issues that men face as they age?
30 seconds.
Don't give the long answer, don't give the long answer. Take care of your blood vessels, take care of your joints. Take your blood pressure medicines, keep track of your cholesterol, exercise a lot, and count calories.
Alcohol?
There's a not unhealthy level of alcohol intake. We try to limit that to less than 1 to 2 drinks a day in men.
Gentlemen, any other comments?
I mean, those are, I think you hit pretty much the high points, staying active,
Are catheters better than they were in the 70s?
Nice.
No. I mean, they are a little bit, I should say that. There have been some improvements, but your bladder knows it's not supposed to be in there, and it fights it. So there's no way to make it 100% comfortable, that's for sure.
Well, gentlemen, I want to thank Dr. Hoffmann, Dr. Hutchinson, and Dr. Nisbet for joining us tonight. This has been a great panel. And I want to thank our medical students, Maddie Grossland, Chris Hughes, and Tyler Kunst. Please join Dr. Ruth Westra next week for a program on arthritis when her panelists will be Dr. Gail Baldwin, Dr. Robert Leff, and Dr. Veronica Mosqueda. Thank you very much for watching and have a great night.